Thank you. Thank you for the nice presentation. And it's a bit difficult to come after all these excellent talks. And I will try to talk a little bit about the need for real-world evidence. And this is my conflict of interest. I think real-world data is important. Of course, we have a lot of randomized control trials, but I will try to go a bit through some of the areas as drug survival, predictors, super responders, safety, and disease prognosis, and how real-world data are important. You all know that during the last 20 years we have had a lot of new drugs, really effective drugs for psoriasis, and we have a lot of really nice randomized controlled trials, many with placebo but also with active comparator, but they mainly show data for the first 12, 16, 24 weeks. Data on effective and safety, but we also need long-time data. And there real-world data can come into place. Also, studies from both UK and also France have shown that the patient who goes into the clinical trials are not exactly the same patient as we see in our daily life. They have tried to put the patient from the registers into the criteria for participating in a clinical trial, and a lot of the patients, actually more than 50%, do not fit into a clinical trial, maybe because they have too little psoriasis, maybe because they don't have just psoriasis vulgaris, or if they have a lot of other diseases, so they could not fit into it. And also, if they look at the efficacy of the patient, whether they are eligible for a clinical trial or not, they can see it's nearly the same effect of the treatment. But if they look at side effect, then the patient who are not eligible for clinical trials, they have much more both adverse effects but also serious adverse effects. So the patient in clinical trials are not the same as we see in our daily life. And this is one of the reasons for us needing real-world data. And we got real-world data from health records, national, regional. We also have them from a big insurance database. And then for all the patients registers that have been developed during the last 20 years, I've just listed some of them. There's a lot more. But from all of this, we get a lot of important data. Of course, there's some good things and bad things with the real-world data. Some of the good thing is that the patients are not selected. We have, at least for the data, the registers on the patient on treatment, prospective cohorts. We have much longer following up. People usually go from one treatment to another, so we also see the effect of second and third line treatment. And the data is more industry independent. There's also bad things about it. They are not randomized. They are quite often affected by the local treatment guidelines. There's not as good adherence as in the clinical trial. In some of the prospective registers, there's not so many patients. In some of the databases, there's a lot of patients, but we don't have the clinical outcome. Quite often, we don't have the baseline data, and we just do not capture dose adjustment so well as in the clinical trials. And it takes some time before we get data on the newest drug. But one of the things that real-world data really have giving information on is the long time efficacy of the treatment, what we usually measure as the drug survival. And the drug survival is the length of treatment until we discontinued, and it's mainly due to lack of effect or side effect. This is just, there's been a lot of trials on drug survival. This is one of the early from the Danish DERM-PU, just looking at the TNF-alpha, and we could see that infliximab have a lot longer drug survival compared to the others. But after that, there has been several studies, and this is some of the news, having much more patients into more than 16,000 patients, and the first is from the France database, where they have an 8 years follow-up of treatment on patient. Their first time biologic treatment. They have only data for this study on the three first TNF-alpha and ustekinumab, and they show that despite the really effective treatment, after 8 years, only about 20% is still in treatment. And as we have heard about several times today, ustekinumab seems to have a much better drug survival compared to the TNF-alpha. The other one is from the bad beer, where they have included all first and second line treatment. And again, they have really a nice drug survival, and mainly for the ustekinumab, and especially for the anti-IL-23, the guselkumab. Also, we have data on second-line biologic if the patient have failure to one. This is again from a French database, where they look at the overall survival of the second-line biologics, and they could show that after 3 years, about only 20% are still in treatment. And if they look on the different classes of biologics, again, it was mainly the IL-23 and secondary the IL-23, IL-12, IL-23, which have the best drug survival. Drug survival studies have also been used to see, shown to see how the patient effect after change to another drug in the same class, and again it shows overall a good drug survival, but still always some of the patient will lose effect. It's not only the effect, it's also the side effect, which is the reason for stopping treatment. And they also show from the bad beer that if a patient stops due to side effects, then there will be a much higher risk of stopping again in the next drug due to side effects. Drug survival studies have also been used to show some of the new treatment we are forced to use. This is data again from the Danish registers, where we just in a few weeks were forced to change from adalimumab original to adalimumab biosimilar, all patients both in treatment and new started treatment. And we could then look at the treatment the year before and the year after and show that there was really no difference in the drug survival between the original drug compared to the biosimilar. Luckily, we also, from all these registers, get data on the more conventional treatment, the conventional systemical treatment, and this is again data from bad beer. Bad beer has really done a lot of publication on drugs, on the real-world evidence, and this shows data on methotrexate in red and acitretin, cyclosporine, and fumaderm, and showing that the early drugs actually have a rather short drug survival. After just 1 year, more than 50% were out of treatment, and methotrexate were the one with the highest but not high drug survival. And next, they actually also compare methotrexate to adalimumab, showing during 2 years that adalimumab has a much better drug survival compared to methotrexate, and also that the patient were actually much more well treated. Data from the real world registers also show that it's important to have a good disease control, and from BAT-BR they have shown that PASI 90, as we use in the clinical trial, but it is more difficult to use in the real world data where we have patient going from one treatment to another and looking at the patient over many years. Their absolute PASI at 2 is much more appropriate, and they have shown that they really correlate and also correlate to a PGA at clear or almost clear. And if we look again into the Danish registers and look if a patient after half a year of treatment have reached a PASI 0 or a PASI below 2, they have a much lesser risk of having flare of their disease, and the flare was defined as an increase in PASI at 3 during the next many years. So it's important to really have a good response in the beginning to have a longer drug survival. Also from BAT-BR they have tried to find predictors for a good response. They were one of the first who published on it, and they look at patient with a PASI 90 after 6 months of treatment, what defined the patient, and they could see there was a lesser or increased risk of having a good response if you were white or have a high PASI, but if you were a female smoker or had a high BMI, you have a lower chance of getting a PASI 90 after 6 months of treatment. And a lot of studies have come after this showing actually the same, that if you have already had one treatment and you lose the response, if you have a high BMI, as we have heard several times today, or if you're a smoker, you have a lesser chance of getting a good response. And some of the data from the real world evidence could fit into the personal medicine, as we have heard that Michael Simpson and also Kathy were talking about, defining who is the one we should treat and how should we treat them, so helping us to a more personalized way of treating. And also it may, in the long run, helping us to identify patient, as we try to do here in the DermView, where we look at super responder, and super responder were patient with taking the same and the first biologics for more than 5 years and not having a PASI about 3 after the first 6 months, compared to non-responder or treatment refractory, which was patient who has at least failure to 3 biologics and 2 different pathways. And if we look at the characteristic, it was the same: high BMI, low social status, high PASI or lower PASI at the beginning. So maybe we could identify patients that we can use all the omics data for to get more information on who should we be more careful and treat more exactly with the measurement as Catherine showed. Besides the predictor of response and drug survivals, the real-world data has also given us a lot of information about the safety, the long-time safety, and also the more seldom side effects. And you know, this is a classic study on tuberculosis which come out immediately after infliximab was introduced into the market, showing that there was a risk of tuberculosis leading to, we are all testing for it now, but also in psoriasis, there has been a lot of studies showing that there is a risk of serious infection, but it is actually lower than we expected, and the risk is mainly related to the TNF-alpha drug and not as much for the IL-17 and IL-23 drugs. Besides that, the safety study has also helped us to disprove suspected side effects. You may all remember when ustekinumab came on the market, there was another biokinumab who was not finished phase 3 trial because of some major cardiovascular event in the clinical trials. So there was a lot of fear of having a major cardiovascular event in relation to IL-12, IL-23. But a large study from US with more than 60,000 patients showing actually that the risk of using ustekinumab compared to TNF-alpha was not increased. So there was not seen more cardiovascular event in the ustekinumab treated patient. Another thing that I think that the real-world data could help us say is that we all know this, and we have heard a lot about this systemic inflammation and the disease, the psoriasis and the comorbidities, and how does it interact. But if we block the systemic inflammation at an early time, would we then inhibit the disease progression? And there has been some studies showing the prevention of psoriasis arthritis. This was one of the first, a small study from Italy, showing that actually patient treated with DMARD compared to patient treated with phototherapy have a decreased risk of developing psoriasis arthritis. However, there has also been several studies showing that patient treated with biologic, as a larger one from from US, showing that actually the one treated with biologics have a much higher increased risk of getting psoriasis arthritis. But as the authors nearly use all the discussion to explain was there's a lot of problem. It is difficult to look at this in the real world data because the patient were not randomized, and maybe all the patients treated with biologics were actually the one with more severe disease and a much higher risk of getting psoriasis. So maybe here we need to have the randomized control trial. So just to sum up, real-world data are important supplement to the control trial. They give us much more information on long-term efficacy and safety. And they have shown that the biologics really are good treatment, and especially the anti-IL-20 drugs. And I hope that they will help us to get a more personalized medicine in the future. Thank you.
Thank you. Questions, Abby?
Yeah, a quick comment and a question. The comment is about the cardiovascular events. And you mentioned the reassuring publication following the signal with the biokinumab. To be fully transparent, there is one publication using the French health insurance database, more than 9,000 patients, and with a case time-dependent model, leaving a little bit of an ambiguity. There would be a signal, it would be minimal, but of course clinically meaningful for the patients, meaning major cardiovascular events might be related to the initiation or updosing, in this case of ustekinumab. So I'm not saying there is a signal. I'm saying there is one publication in JAMA Derm that leaves the ambiguity open, right?
And also the first from US coming after, it also,
because
so there has been some.
because the
I
power, I
agree.
mean, to have the power to show, you know, an effect requires an immense kind of power, a scale up that we can't reach. So there should be some thinking, maybe with the epidemiologists could work around that. The second is, are you aware of, and that's a question for you, Catherine, and I guess, and maybe Oliver, of a bunch of patients who, in real life, patients with PSA and psoriasis, who respond for the skin involvement optimally to the drug approved for PSA and not for psoriasis, and namely the Janus kinase inhibitors, upadacitinib and tofacitinib. Are you aware of a study that would capture that? The patients that would respond optimally to upadacitinib and tofacitinib and not to the TNF-alpha blocker, to the IL-17 blockers, to the 23 blockers. Shouldn't be a lot, but that's a question for... Because I saw a handful of these patients in real life.
What, that are responding to Janus kinase?
Yeah.
Yeah, but nothing else.
But we come.
Yeah, that's my point.
Well, we
Are you aware of
certainly-
any study that would capture that?
I'm
in
not aware
real
of any,
life?
no, not any, I'm not aware of any real, but I agree with your observation.
But in the clinic, we, not very often, but we use the JAKs for the arthritis and then the biologics for the skin. So, but of course, it's very few patients, but we have few patients who are where the skin is totally clear, but they still have pain. And then we have to supplement with methotrexate and a JAK, and just to kind of control them in any way. So, but we have those patients.
You know, I was not referring to the combination.
Yeah.
I was referring
Yeah, I
to
know.
the kind of pure Janus. You know, there are not many. I know that for a fact. But because there are, what, in Derm Bio, the 6.5% of primary non-responding.
It was a combination of primary and secondary non-responding.
You have the primary non-responding. So, of course, there are not a lot, but they might be interesting to dig deeper, right,
Yeah.
regarding this.
I'm for sure that is something, and try to take the patient and sample them, take biopsies and blood, and send them to Johan or someplace and have more information on them.
Thank you.
Why is it that women respond less than men? Why is it that? I've just
Kathy has some
in the.
On the obesity, the change.
But this.
I don't think the data says they respond less well.
But yeah, do they want to be more clear?
Yeah,
Yeah.
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 And women have much more side effects compared to men.
More side effects, and they
Yeah,
want to
that's
be
for
more
sure.
clear than men. Yeah, they have they could request that we change drug earlier than.
Hang on, I'm not sure that there's...
But it's just an impression. But with the data shows that the drug survival is different.
I mean, but the basic biology of psoriasis and differences between the sexes is actually really not being systematically...
No, but the question is why.
So there may be...
Clinical trial data, there's no difference, right, in male-female responses.
Yeah.
So it's real-world stuff. It has to
Yeah.
be something in the real world.
Yes, that was my question.
And
Yes.
adherence to drug is not as good, of course, in real world. Sorry?
Yeah.
There is a study just starting within RAPA, which Leahy Eder is leading on, called the SAGE study, which is comparing responses in females and males, and comparing responses over time, and looking for absolute.
But yes, Catherine.
The other thing is that there's probably differences in terms of men and women and how they access treatment. So the
Yes. Yeah. But yeah.
yeah.
Now, one explanation, but definitely not the only one, is which kind of outcome measure you use. Because women respond much less in the DLQI dimension and in the PASI dimension as compared to men.
But in the real world data, we don't use the DLQI, or we don't use the PASI to we use a patient. It's a patient request whether they want.
The DLQI is a readout of the patient.
Yes, but I don't use
But it may be a reason to stop if they don't feel
yeah,
well.
but still you have patients who has a PASI 100 or a PASI 0 and have a DLQI of 10. They still exist. Okay.
So coexisting fibromyalgia is not uncommon.
No.
And certainly much more common in females than males.
Yeah. Okay.
It would be interesting to do a real-world study, though, to test the same amount of skin disease in a man and woman, whether, the LQI or other, with the same amount of,
Yes,
same
yeah.
amount of BSA in a man, whether they tolerate less or not.
Yeah. Oh, the final question, yes.
No, sorry. From the time a friend that is connected, she said, please speak through the microphone because
I think I do.
people that are virtual doesn't
Yeah.
listen.
Okay, I
I just
think.
have one thing. All the abstract, I don't sure that we have said it, but all the abstracts from today are published in Acta Dermatovenerologica, if you want to see them.
Good. Thank you.